Hello guys, welcome to the channel, welcome to the live stream. We'll be starting in 5 minutes, so please stay logged in and we'll start soon. Please tell me in the comments if the audio is okay. I think it should be okay by now. I am quite trained to adjust the audio, but just type in the comments. Thank you. Guys, please take some time to subscribe to the channel and like the stream and share the video link with your friends so that they can also join. And in 2 minutes we'll be live and in the stream, and I'll start the ECG. Eric, आ रहा है? Hello guys, welcome to the channel, welcome to Health Music Fitness, and welcome to the live stream. And we'll be starting a fresh series of ECG learning streams, and today will be the first ECG stream. Okay, in this I will teach you how to and what about all about ECG, and we will start right away. I am Dr. Robert James, and I am MBBS and MD in medicine from Christian Medical College, Ludhiana, and I'm also a fellow in clinical cardiology and 2D echocardiography. So we'll start the lecture, and first of all, like I always give credit to God, and God, Guru and Seeker, we are all in one person. And when the student is ready, the teacher appears. Okay, so right now you are listening and watching this lecture because it's time for you to know the ECG basics, and because in few months like you will be doctors and certified doctors, so we should save more and more number of lives, and that we can do if we know the ECG and how to interpret the ECG properly. Okay, so this is the small circle which I will be coming back to again and again while I am teaching you ECG, and this is the DNA of electrocardiography. Okay, and I'll tell you how we made it and what's the significance of it. So there is nothing to by heart in the ECG. Okay, it is like ABCD or 1 2 3 4, and if you know the alphabets or the numericals 0 to 9, and you can solve any complex mathematical equation. Okay, but we have to know what 1 2 3 4 till 9 are. So that's the thing about ECG, and I'll go a little bit into the history because it is important, and we should give due credit to all the teachers who taught us, who spent their lifetime discovering the different findings and tracings in the ECG, what it means, what it meant. And Einthoven was one, and in 1924 he got a Nobel Prize also for discovering so many ECG changes in various cardiac disorders and non-cardiac disorders. And based on his name, we have Einthoven's triangles also, Einthoven's triangle. Okay, so is the audio okay? Eric, is the audio okay? Audio okay. So this is Einthoven's triangle, and you don't have to take this very seriously. I have to teach you because I'm teaching you full ECG thing, and but you should know like how the leads are placed in the ECG. And like lead 1, there is always a positive pole and a negative pole of every electrode, every lead. Okay, and this is the positive pole of lead 1 at left arm, and negative is at right arm. Then for lead 2, negative and positive, and lead 3, negative out here and positive out here. Okay, so you can remember like lower limb, like it's all positive only. Okay, then you invert this triangle and make a circle. Okay, you don't have to go into how it is made, you just by heart it. Okay, this is the circle, and based on this, that circle which I showed you, which I have made, like it is the crux of ECG. If you know that circle, you will be trained, and you can discover all the changes in the ECG. Your mind will be so trained, by the time you are reading the ECG strip like that, your brain will map all the different leads on this circle in your mind. Okay, so for the first 100 ECGs, let's say, you have to actively think about this circle while you're reading. Place lead 1 on that circle, place lead AVF and all the leads. Okay, and it is very important to know that there is a positive pole and a negative pole of each lead. Okay, and please remind me when 1 hour is over, because my lecture sometimes goes very long and then it becomes boring. Okay, so at 1 hour please message me in the comments box, sir 1 hour is over, and I'll continue in the next hour. That will be fine. Next day. So this is the circle. Okay, it's the same circle, Einthoven's triangle, which we have made out here. So in this you have to remember there is a 0 degree out here, 180 degree out here. Okay, you just by heart this, minus 90 out here, okay, plus 90 out here, and you have to remember all the leads are placed at multiples of 30. Okay, right now it is very confusing for you. Just listen to me, and after few slides you will come to know everything is okay only. So like lead 1 is at 0 degree, then 30 plus 30 60 degree, lead 2 is at 60 degree plus 60, lead AVF is at plus 90 degree, 60 plus 30 90, okay, like that. And this part of the hemisphere circle, this hemisphere is positive and the above the diameter is negative, okay. So that's important. So this is positive, this is negative. So let us say lead AVL, it is at minus 30 degree. This is the positive pole of lead AVL. Okay. Here I have plotted all the positive poles where I have named the leads. So the negative pole of lead AVL will be straight opposite to it at minus 30 degree. Negative pole will be at plus 150 degree. Lead AVF positive pole is at plus 90 degree. Negative pole will be at minus 90. So like that we have to remember. Okay. So this is the importance of this circle. Now, why you need to do ECG? Because coronary artery disease, you know, it is very prevalent, and because of a bad lifestyle and bad eating habits and increasing stress in our lives. So our heart takes the brunt. Okay, blood pressure is there, diabetes is there, and smoking, people smoke, and alcohol is there. So a lot of things, they cause an insult to the blood, to the myocardium, and patients will come with all the signs symptoms suggestive of MI or coronary artery disease to you. They'll come with heaviness, squeezing pain in the chest, choking sensation as if somebody is sitting on their chest, and that pain, that weight is just not going, left neck pain, left jaw pain, pain radiating to the medial aspect of the left arm in person who has heart on the left side, and things like that. Okay, the patient may come to you with hypotension and nausea, vomiting. So that is like usually you will see these symptoms in inferior wall MI. You just keep on noting it down, and you can come back and refer to this video again, and you can have pen and paper and book and note it down. It is always good to have a notebook when we have series of lectures. And patients can also present with GI complaints. They can have severe pain in the abdomen and colicky type of feeling, sinking sensation, and this is because of vagal stimulation in inferior wall MI. Usually in inferior wall MI you will have these atypical signs and symptoms. So what all can you use ECG for? Okay, so there are a lot of things. In almost every medical condition your heart will be affected. You can check the heart rate, you can check the rhythm, and you can check the axis of the heart. You can diagnose coronary artery disease, you can diagnose many of the valvular heart diseases, because it's not that like echo you can see the valve in the ECG, but because of the valve problem, like in aortic stenosis, you can get features of left ventricular hypertrophy. There are electrical criteria, voltage criteria. Eric on karo, Eric left jaldi on karo charger. Sorry, my battery is sinking. Okay, so that's fine. I forgot to put the charger on, so Eric is sitting here to help me, and thank you, Eric. So we were talking in what all conditions the ECG is helpful. Then you can diagnose myocardial diseases, acute MI or ischemia, valvular heart diseases, aortic stenosis, mitral regurgitation, left atrial enlargement, like in mitral stenosis you see. So you can get indirect hints as to what type of valvular heart disease it will be. If you see in the ECG just left atrial enlargement, we have to think of some sort of obstruction at the mitral annulus, mitral valve. Okay, so because of which through the tight orifice the left atrium has to pump blood into the left ventricle. So like that. Then in COPD you can see right ventricular changes, you can see right ventricular hypertrophy, right ventricular dilatation, because your right ventricle has to pump blood into the pulmonary artery. Okay. So like these, like there are a lot of things. And then in autoimmune diseases, in SLE you can get limb and sac endocarditis and mitral regurgitation, fenestrations, which obviously you will see on echo, but you will get some sort of sign or symptom in the ECG. Okay, you can get in dengue fever. In dengue fever you can get first degree AV blocks, and in myocarditis you can get different types of findings. Okay. So it is very important to know the ECG, because almost in every disease, even in kidney disease, most of the time patient has hyperkalemia, chronic kidney disease, hyperkalemia they can have, and in ECG you will see tall, hyperacute tall T waves, which you will see in hyperkalemia. So, like this in almost every disease, in electrolyte imbalance, in hypokalemia, you can see U waves and other things, ST depression and T wave flattening, and in hypocalcemia you can see prolonged QT interval. In response to certain drugs, because of digoxin, you can see digitalis effect, you can see digitalis toxicity on the ECG. So, if your patient is on digoxin and the patient's having nausea, vomiting, so you do digitalis levels and they will be high, you see in the ECG there will be a digitalis toxicity sign in the ST segment. Many poisonings you can detect on ECG, morphine poisoning, organum phosphate poisoning, and cell-phos aluminum phosphide poisoning, which will simulate just like myocardial infarction. So, like that you will see a lot of changes. Okay. Now, we will learn how to attach the leads. So, in the fourth intercostal space on the right side, you will place the V1, then V2 on the left side of the sternum in the same space, then V4 in the fifth intercostal space, mid clavicular line, V3 in between V2 and V4, then V5 in the same fifth intercostal space line and anterior axillary line, and V6 you will place in the mid axillary line. Okay, so, this is the conventional placement of anterior chest leads. There are 6 anterior chest leads. Okay, so, these are 6. Usually on the machine, on the electrodes, you will see the leads are hanging like this, and there are different colors allotted to violet, indigo, blue, green, yellow, orange, red, like that, with your pattern they follow usually. Then there are other leads. Okay, so, we will come to the leads later on. So, now we come to what is a pacemaker. Okay. So, how the heart fires. So, pacemaker is someone which will set the pace. So, there are many pacemakers in the heart, but the SA node is the main pacemaker. It sets the pace of the heart. So, heart beats at that speed. Okay. Like in marathon running. Now, out here you see these two are pacers, they are Kenyan runners, but this is the real person who is participating in the Olympic. Okay. So, these pacemakers, they are so accurate, by the second they will make sure their partner, this person who has hired them, wins the race by even a millisecond if possible or more than that. So, that accurate they are. Okay. So, out here you can see Eric is running, my son, that's his first marathon. All these big boys in red t-shirts, they are the competitors, and I am pacing Eric. Okay. I was doing my first full marathon, 42 kilometers. And so, SA node is the pacemaker, it sets the pace, and SA node is the fastest firing pacemaker, and it fires at around 60 to 100 beats per minute. Okay. Then the second firing fastest is the AV node, it fires at around 40 to 60 beats per minute. And then the ventricle myocardium, there it can also pace the heart when both SA and AV fail. Then ventricular rhythm will be at around 20 to 30 beats per minute. So, that is a life sustaining beat, and it should not be suppressed. I will tell you which leads we have to, which arrhythmias we have to suppress and which we do not have to suppress. So, these are different pacemakers. So, God has made our body in such a way that heart has to sustain life. If SA node stops firing, the pacemakers in the atrium, they will take over, they will try to take over, and if they do not fire, the AV node will take over. If that does not fire, the ventricular myocardium will start firing, and the electrical activity will start, and we will try to sustain life and try to give oxygen to our brain. So, that is the beauty of heart. It will never ditch us, and it will always try to keep us alive. So, this we have already discussed. SA node is the fastest firing pacemaker. So, this also we have discussed, and okay. So, now you can see in this picture, this is the SA node and this is the AV node, and this is the bundle of phase, and from here the left bundle branch arises, which supplies the interventricular septum and the left ventricle. This is the right bundle branch which supplies the right ventricle. Okay. And sometimes there is a septal fascicle also, which arises from the left bundle branch or from the left anterior fascicle of the left bundle branch or left posterior fascicle. Now, at this point only I will tell you. So, left bundle branch further divides into left anterior fascicle, which lies superolaterally out here. Okay. Then left posterior fascicle lies inferomedially out here. There is a significance of this, and the septal fascicle can arise from left bundle branch, left anterior fascicle, left posterior fascicle, or left anterior and posterior fascicle, or some version of this. Okay, it will septal fascicle will supply the interventricular septum. So we come back to this diagram again. So this is the master diagram. If you see this nicely and memorize it, it will really help you. See, SA node has fired and it is firing into the atrium, and the atrium are getting depolarized. Then the same impulse reaches the AV node, bundle of phase, right bundle branch, then left bundle branch dividing into left anterior fascicle, left posterior fascicle. Okay, and you have to remember the depolarization starts from left to right, and interventricular septum is the first to get depolarized in the ventricles. Okay, interventricular septum is part of the myocardium. It lies between left and right ventricle, and it is like a wall between the left and right ventricle. So left ventricular failure can lead to right ventricular failure. Right ventricular failure can push the heart in interventricular septum towards the left side, and it can decrease the cardiac output. So both ways your heart can fail, and it can fail each other's chambers. Okay, so this you have to remember. So this we have done, left anterior fascicle, left posterior fascicle, and I have already told you interventricular septum, it is the first to get depolarized from left to right side. So patients will come to you with chest pain. Okay, so how do you diagnose a person with chest pain, whether he has MI or not? They may not respond to sorbitrate or nitrates if there is myocardial infarction. Usually anginal pain, it subsides with administration of nitrates. So there is something called as Kussmaul sign, and this we can come to later on. Okay, we will come to the ECG. Okay, so now we come, what is QRS complex and how it is formed. Okay, so QRS complex is like the sum total of electrical activity of left ventricle and right ventricle. But you must remember, right ventricle is very thin because it has to just pump blood into the lungs. Okay, and left ventricle has to pump blood into the whole of the body. So it needs muscular myocardium. So left ventricle is thick walled, the muscles are thick and good and powerful. So the electrical activity of the ECG seen in ECG, the QRS complex formation. So most of it is contributed by the left ventricle. It's not like in different leads, different ventricles will show the electrical activity. It's a sum total of it. Okay, so same. Okay, now what are the different complexes? There is a P wave, there is a QRS wave, and there is a T wave. So atrial depolarization causes P wave, ventricular depolarization causes QRS complex, ventricular repolarization causes a T wave. Okay, so you have to remember this. Now the actual lecture has started just now, but that part of the history and historical background we need to know. It is always good to have some connection with the clinical side when we are doing or discussing the ECG also. Okay, so now you draw that circle in your mind around this picture, that same circle. Okay, lead 1 is at 0 degree, AVF at plus 90 degree, like that. Okay, now whenever the impulse is coming towards the positive pole of any of the electrodes, okay, so whenever the impulse is coming towards the positive pole of any of the electrodes, it is perceived as a upright deflection, like a R wave. So out here you can see R wave, this is a R wave. Okay, and whenever the impulse is going away from the positive pole of that electrode, it is perceived as a negative wave, S wave. Okay, so let us say this is the diagram circle. So SA node is out here, SA node is out here, it is firing. So when it is firing, the impulse is always going towards left ventricle. Okay, so in other words, it is going away from AVR. AVR is at minus 150 degree. So that will cause a negative P wave, negative QRS wave, and a negative T wave. Now see, if you observed, I said QRS, negative QRS, but it is not like that. There are different types of QRS complexes. If there is this is a small q. Okay, you have to learn to recognize this small q, this negative deflection, initial negative deflection. This is a p wave, this is a small q, this is a r wave, and if there was a s wave, it would have been like this. In this there is a s wave. Okay, p wave, r wave, s wave. Okay, so rs complex, q complex. Okay, so normal q we will denote as small q. A pathological q after mi we will denote as capital Q. Okay, so QS, but for the beauty, because when we write QRS, small q doesn't look good, so most of the cardiologists, they will write QRS, or even normal q they will write as capital Q. Then this is RS complex. Okay, this is R complex, and this is Q complex, this is RS complex, this is QRS. Okay, so like this there are different variations of QRS complexes, but by default we just say QRS is positive, QRS is negative, and things like that. Okay. Okay. Now, what is the function of Purkinje system? Now, Purkinje's fibers, they are in the myocardium. They are like a meshwork. Like now, you must have seen on the buildings, on the walls, on Christmas Eve, and now New Year is today. And it is a very good thing you are entering into New Year with by learning something new, the ECG. Okay. So you see, whenever the lights are lighting on a house, all the lights, they will blink nicely and they will stop. Then they will blink nicely and then they will stop. So Purkinje fibers also have the same sort of function. So when the myocardium is activated, depolarized, it's not that the apex will first contract and then the lateral wall or the posterior wall. So it's like a nice squeezy contraction which pushes the blood into the major artery, into the aorta or the pulmonary artery. Okay. So this is very important. So Purkinje fibers, they will pass the electricity, the current through to all the myocytes at one time. Now we come to what are the different leads. So there are 6 anterior chest leads, which we have already discussed, V1 to V6, and sometimes when we want to record right ventricular changes, when we want to look for right ventricular MI, okay, then we will take V3R, V4R, V5R like that. So V4R, if there is ST elevation, that is very diagnostic of right ventricular infarction, because right ventricle is not covered by these standard leads. In V1, V2, little bit of the right ventricle you will see, but the rest of the right ventricle is beyond V1, V2. We will again come back to that same circle. I will just show you. Okay. Okay, so now you see this is V1 is out here. This circle is my imagination, and you can by heart it. It works in all the conditions. V1 is out here, V2 is out here. So they are looking over the right ventricle, but for some time only, just this much area. Then V3, V4 over the interventricular septum, V5 at the LV tip, and V6 is little out here. Okay. So this part of the ventricular electrical activity you will not see in V1, V2, and for that you will have to do V3R and V4R, V5R. Usually V3R, V4R you need to diagnose right ventricular infarction. Okay. Then there are standard limb leads, lead 1, lead 2, lead 3. So in that circle you have seen lead 1 is at 0 degree, lead 2 is, these are the positive pole of all these leads. Lead 2 is at plus 60 degree, lead 3 is at plus 120 degree. Then there are augmented limb leads. So they are denoted like this, small a and capital VR, VL, VF, AVR, AVL, AVF, and then there are anterior chest leads. So whenever you are given an ECG, you have to interpret and see the ECG in the same pattern. Okay, you have to train your mind like that. So lead 1, 2, 3, AVR, AVL, AVF, V1 to V6, and then maybe V3R, V4R. So like that you have to train your mind. It's not like you start from V6, V5, V4, V3. So that is wrong. Okay. So like that you have to read the ECG. Now what is the speed of the paper? Now on this, if you see any ECG paper, you see the rhythm, okay, somewhere on the top or on the bottom in small alphabets it will be written 25 millimeters per second or 50 millimeters per second. That is very important. Normally, conventionally, you will see ECG paper is coming out of the machine at this rate of 25 millimeters per second, okay, and but sometimes we need to change the speed, we need to make it 50 millimeters per second, which means supposing if the patient is having very bad tachyarrhythmia, very bad ventricular tachycardia or supraventricular tachycardia, and the rhythm is like this, and you just can't make out with PQ or ST whether P wave is there or not, okay, it's very important to diagnose supraventricular from differentiate supraventricular from ventricular arrhythmia. In that case, there will be a button on the machine, you make it 50 millimeters per second, and then you will see a nice P wave, QRS, all those complexes if P wave is there. If P wave is not there, you will see nice QRST, QRST, QRST like that, okay. So it is very important to differentiate supraventricular arrhythmia from a ventricular arrhythmia. When the arrhythmia is arising from the ventricles, obviously there will not be a P wave. If the SA node is firing, P wave will form. If the SA node is not firing, P wave will not form. You can have abnormal P waves arising from the atrium, that we will discuss later on. In ventricular arrhythmias, ventricular tachycardia, you will not see P wave, okay. So this is, and QRS complex will be broad because of certain things, and QRS will be broad. In supraventricular arrhythmias, QRS usually is not broad. There are certain exceptions like WPW syndrome, in which there is an aberrant pathway and the conduction is taking little longer. So in that QRS can widen, but that is it's too early to discuss all those things out here. Now we come to is 7:28. So please message me in the comments box and tell me when it is 8 o'clock. So how to record an ECG? How to record RVMI, posterior wall MI? So I've already told you. So you have to place the leads on the right side. Okay, heart is out here. So to record the right ventricle, so V2R, V1R, V2R, V3R, V4R, V5R, V6R. We need basically V3R, V4R. Okay, and sometimes we record posteriorly also the ECG like V1, V2, V3, V4, V5, V6. Then posteriorly we take V7, V8, V9, V10 posteriorly on the left side. That is to record posterior wall MI. Okay, so this is a take home message. So right ventricular changes you will see in V1, V2, then V3, V4. So that is the area which will pick up the right ventricular infarction changes. Okay, posterior wall infarction you will see mirror images in V1, V2. Will come to that later on. Too early to discuss now. And in V7, V8, V9 posteriorly on the left side. So again we are back, and just take a mental image of this again, because for the rest of your life you will be diagnosing based on this circle only. Okay, V1, V2, V3, V4 of the interventricular septum, V5 is the tip. So now you see V5 is the tip of the LV. So the best R wave you will see in V5, wherever the myocardium is good and it is bulky, abundance is there, functional myocardium, you will see a tall R, tallest R there. V6 also will have a tall R, but it will be less tall than V5. If lead V6 shows a taller R than the R in V5, that means there is a concentric LVH. Okay, we will come to those electrical changes, vector changes in LVH later on. But our fundas about ECG, how to take the ECG and how to record the ECG have to be right. Okay, so one sec please. Okay, now get the calibration right. This is the most important message for today. And what is calibration? Now you will say, sir, what is calibration? Now I have placed this small dummy thing out here, because the dummy series, if you know, if you have read the dummy books, they are the best books. Okay, DOS for dummies and Java for dummies. I used to learn computer programming, and they will teach you thinking that you don't know anything about computer or anything about medicine or anything about any subject. The dummy series you can check online, and there might be a book, dummy book also for ECG also, and it will tell you basically what I am telling you. So in a very simple way. Now what is calibration? see, when the machine calibrates, okay, it fires a vertical upstroke, then a horizontal upstroke, then a downstroke. Okay, so it has to go, the impulse has to go 10 small squares up, then horizontal, then 10 small squares down. That is a good calibration. Now out here you see calibration is just 5 small squares. Okay, so this will give you half the size of complex in the ECG. And so if supposing on the calibration in the, if I give you an ECG and this type of calibration is there, the first one, and you see in V5 R wave is, let us say, 10 small squares in height. That means R wave is 20 small squares in height actually, because this is calibration is for 5 only. So it is that important. And if this up horizontal plate, if it goes like this and it comes down like this, the ECG will record a false R wave. Even if the patient is having Q wave, it will become R wave. Okay, so it is that important. And if it is the other way around, let us say it is going up and then like this and it is coming down, it will form a false S wave or a false Q wave. So the calibration has to be accurate. Now you see in this ECG, this is the calibration. Always look at the calibration. Okay, calibration is very important, very important. So if you are not given this calibration, you can actually ask the teacher, ki sir, I want to see the calibration, because if this is 5, then this would mean it is 20, because it is 5 and 5 small squares 10. So but this is 5, so we have to double it. Okay, so calibration is important. So this is a normal ECG and normal ECG paper. This is a good P wave. This is a Q, this is a RS, I will say QRS only. This is a QRS complex, this is the ST segment, and this is the T wave. And see, now out here you can see ST segment and T wave is starting out here. Okay, and in MI there will be subtle change, merging of ST with T. So with the proximal limb of the T, the ST merges. So you will find it very difficult to say, sir, ST is ending here. Okay, that will be the subtlest sign of acute MI, hyperacute MI. After that you will get hyperacute T waves and coving and all those things. So I want you to be this good, you have to pick up an MI at this merging point, merging level. Now we come to the ECG paper. So first thing is 25 millimeters per second. If there is a ventricular tachycardia or very bad PSVT, you can't see the P waves, you double the speed 50 millimeters per second and you will get a good PQRST complex. Then ECG, this is the ECG paper, it is a standardized paper, and there are 5 small squares and horizontally, 5 small squares vertically. Okay, and then it makes a big square like this. Okay, so one small square is 0.04 seconds, 0.04 seconds or 40 milliseconds. Then one, so there are 5, so 5 was a 20, 0.2. So one large square is 0.2 seconds or 200 milliseconds. This will be very important when you calculate the heart rate for a patient with atrial fibrillation, because in atrial fibrillation the RR interval will vary. Okay, irregular heart rate. We always say, sir, the heart rate is irregular in mitral stenosis, atrial fibrillation. So in that case you have to calculate the heart rate, number of R waves in 1 minute. Okay, so this is 0.2 seconds. So you multiply into 5, that will be 1 second. Okay, multiply into 6 seconds into 10. Okay, so 6 10 60. So for 1 minute you can calculate the heart rate like that. So it is very important and you have to calculate. And this is the isoelectric complex, this is the isoelectric line where all the complexes, they will start and end. So you can see the P wave, it is starting from here, it is ending at the isoelectric line. QRS is starting at isoelectric line, ending at isoelectric line. T wave is starting at isoelectric, ending at isoelectric line. So this is the ideal good ECG of a healthy heart. And sometimes the isoelectric line will be wavy and you will not see the P waves, that will become atrial fibrillation, irregular heart rate. And sometimes the isoelectric line will not be isoelectric. So you might see this type of ECG pattern. So it will be difficult for you. So then you have to make sure the grounding is good and the patient is grounded properly on the bed, and after the heart rate settles down, you can take another ECG just for teaching purposes, like that. Now when you interpret the ECG, you have to always interpret it like this. Okay, don't just if I give you the ECG, okay, read, anybody, Ranjana or Priya, anybody, you read the ECG, so you will just start in a panic mode. First of all, you have to calm down, and then only you will your brain will register the issue. Okay, so rate, rhythm, axis, rate, rhythm, axis. Okay, never bypass this step, because I told you the normal heart rate is 60 to 100 average. Okay, if you are an athlete, you are a runner and exercising regularly, your heart rate can be 50 also, that's fine, that's an exception. But if your average, on an average, the heart rate is 60 to 100. So what's the importance of heart rate? We have ruled out tachyarrhythmias, tachycardias. We have ruled out bradyarrhythmias, bradycardia. If the heart rate is less than 60, so you have to think of all the blocks. Okay, first degree AV block, second degree AV block, third degree AV block, because the blocks keep on varying and merging into each other. Okay, and SA blocks, and you have to think of all these things, and different diseases which are causing bradycardia, sclerodegenerative diseases of the heart, electrical conducting system, hypothyroidism, some poisonings like morphine, organophosphates, so poisonings, and like that. So your brain will be working on a different track if the heart rate is less than 60. Okay, if it is more than 100, then you have to think of tachycardia. It's a tachycardia and tachyarrhythmia. Then you look at rule out the causes of tachycardia: hyperthyroidism and anxiety, excess of caffeine ingestion, fever, and some drug side effect. Okay, or is it a ventricular tachycardia, or is it a junctional tachycardia, or is it a idioventricular rhythm, or what it is. Okay, so rate is very important. Then rhythm. So rhythm is like, normally you will say it's, we'll go back to the same ECG. So okay, so this is a normal sinus rhythm. What do you mean by normal sinus rhythm? Normal sinus rhythm is, the rhythm is arising in the SA node. Again, go back to that circle. Okay, the SA node is in the right atrium. Okay, lying posteriorly. So SA node has fired. So that is a normal sinoatrial node. Okay, remember like that. The P wave arising because of the electrical stimulation from the SA node, that is normal sinus rhythm. So in the normal sinus rhythm, you will see normal looking, good looking P waves. They won't be irregular or haphazardly pointing here and there. It will be centralized, a nice peak, not very flat, not very tall, a good amplitude P wave, and then a good QRS complex, and a good ST, and a good T, ending and starting and ending at the isoelectric line. Normal sinus rhythm. All the P waves in the rhythm strip, they will look nice and identical. Okay, like in this rhythm. This is an ideal example of a normal sinus rhythm. And I told you, whenever the current, no, I think I didn't tell you. So whenever the current is going towards the positive pole of any of these leads, again go back to the circle. Okay, so that lead will record a tall R wave, positive complex. If the current is going away from the positive pole of any of the leads, so it will record a negative complex. So I will show you some ECG in which I can show you. Okay, now see in this positive pole in lead 1, positive R in lead 1, where is AVR? So AVR is showing inverted complexes. This is not a normal ECG. So why in AVR all the complexes are inverted? So we have to go back to the circle. Okay, so AVR is at minus 150. SA node is beyond 150. Heart I have drawn in the center. So SA has fired. The impulse is always going towards lead 2. Lead 2 is placed at plus 60 degrees. So diagonally towards lead 2 the impulse is going. So lead 2 will record the best P wave, best R wave, and best T wave. Okay, and at this point you remember, again take home message: T follows R. Okay, T wave will follow the R wave, and if this rule is broken, the patient is having some serious problem. Okay, if R wave is of good amplitude, T wave has to be of good size, good positive T wave. If R wave is very tall and T is not tall, T is very small, it could be the subtlest sign of ischemia happening, okay, or T could be flat. In the worst forms, ST will depress and T will invert, okay. So you have to pick up at that point. If the T is not of good size and R is of good size, it could mean ischemia. And all these amplitudes you have to remember very nicely, observe very nicely in each ECG, in each lead, because sometimes in non-QMIs, in N-STEMIs, you might see just the amplitude of the R waves in V1 to V6 that has decreased and nothing else is there. There is no Q wave, there is no hyperacuity, there is no coving happening, and that will be just the sign of N-STEMI, and drop T will be positive. So now for AVR, what is happening? SA has fired. Remember that circle again. SA has fired. Impulse is going towards the atrium into the ventricle. So it is going away from AVR. Okay, AVR is out here, minus 150. It is going like this. So for AVR is now not happy. It is saying all the impulses are going away from me. So it gets sad and it draws negative complexes, negative P, negative QRS, and negative T. That is the normal ECG. That is the normal AVR. Okay, it is not abnormal. If something is positive in AVR, if ST is elevated in AVR, it could be a very bad sign of right ventricular MI or inferior wall MI or some lateral wall MI or something like that. Some arrhythmia is happening or some junctional beat is firing upright. If you see a upright P wave in AVR, which means SA is not firing, the junctional rhythm and AV node has fired up and down. So you will get a positive P wave in AVR because the impulse is now going towards AVR. Okay. So AVR is happy, okay, at least P is coming, so it will make a positive P, and rest of the leads they will show a negative P wave, because in that case P is going towards AVR, and this for these leads the current is going away from them when the P wave is being formed. So they will draw a negative P wave. So it is very interesting to observe all these things, but your fundas have to be really sharp and right, okay. Then the next important thing is axis, okay. So axis is very important, and we'll come back to the same circle again, and this will come to later on. So axis, you have to see whether it is a normal axis or a left axis deviation or a right axis deviation, or whether it is extreme RAD or a extreme LAD, okay. So I will come to that circle again. We'll just go through this slide. Then now you see P wave, it shows atrial depolarization. PR interval equals to from beginning of the P wave to the beginning of the QRS complex. QRS is less than 3 small squares, 0.12 seconds, 0.12 seconds. Okay, just by heart these things, and that will be fine. ST segment, so it is important in acute MI. It will be depressed in ischemia. It will be elevated in MI, Prinzmetal's angina, or some myocarditis changes you will see. Then QT is from the beginning of the Q to the end of T wave, okay, very important. And QT interval is inversely proportional to heart rate. So if QT is more, heart rate will be low, like in hypocalcemia, quinidine toxicity and all. Then T wave will show ventricular depolarization, and if R is good, T has to be of good size. Okay, I think we'll stop here, and rest of the ECG will continue tomorrow, and at this point we'll stop. So thank you all for joining, and wish you today's Happy New Year. So I know you must be eager to go and enjoy. So we wish you all a Happy New Year, and have fun and be safe, and God bless you all, and we'll continue this session in the next year tomorrow. Bye bye. God bless.